Hello, I'd like to welcome you to this session from our Highlights in Medicine conference in 2021. My name is Cory Neudorf, and I'm a professor here in the Department of Community Health and Epidemiology at University of Saskatchewan. And on the practice side, currently the interim senior medical health officer with the Saskatchewan Health Authority and also president of the Urban Public Health Network of Canada. Today, I want to be speaking to you and thinking about our post-COVID or post-pandemic world and what lessons have we learned to take forward and building back stronger as we rethink provision of medicine. What I want to cover is I'll give a very brief timeline and some reflection about our COVID-19 response to date, particularly in Canada, and a little bit of extra analysis or thinking about how COVID has impacted us from an equity perspective. Then I want to reflect a bit on some lessons learned. Obviously, there's a lot of lessons that we've learned from our COVID response, but I'll highlight a few. And then reflect on how our work in medicine might look different post-pandemic. So let's start. Just a bit of background, not that people need a lot of background about COVID. We've all been living it for so long. It was back in this December 2019 to March 2020, really, when SARS-CoV-2 emerged as a novel infection and spread quite rapidly globally over the course of weeks to a few months. And if you think back, our initial control measures in Canada for this kind of a novel virus had many unknowns, obviously, and this by necessity was very broad-based and general kinds of responses, but very much in keeping with what other countries were doing in response to reports of how countries hit earlier than us were having huge impacts both on their health system and in terms of deaths, particularly in what was emerging as vulnerable populations for SARS-CoV-2. So specifically in long-term care homes and in the elderly and those with underlying medical conditions. As you recall, healthcare systems in those initial countries hit very hard, overcapacity very quickly, and gave us some heads up as to the kind of preparation we would have to do, and hopefully some things that we could do to avoid that kind of overcapacity in our country. At the same time, a lot of computer modelers and epidemiologists got busy looking at the initial reports from these other jurisdictions and then refining those models as more and more became known about the virus and its transmission patterns and how it impacted different age groups and subpopulations. So what we ended up with was continuously updated models on the potential for exponential spread. And a key learning for me through this was the difference between modeling that showed what would happen without any intervention versus just the intervention that people themselves had by looking at what was happening in other countries and adopting certain behaviors even before they become widespread through government mandates. But then also modeling what would happen to those projections if certain types of restrictions were followed. And a bit of an interesting dance in that as we've gone through the pandemic, in that worst case scenarios usually didn't come to pass, and that's because we didn't have a scenario where things just carried on as normal, that there was always some sort of intervention happening, either through public following advice and hopefully with stronger following after government interventions announced. So we ended up with often middle of the road impacts compared to what the worst case scenario was. And in a few cases where restrictions were followed more carefully as per scientific advice, then we actually had some of the best case scenarios start to come out. But what we had then was mitigating effects of these restrictions that were blunting the waves that we had. And early on, even in the pandemic, drawing from previous pandemics, we knew that this would come in waves, likely over the course of at least 2 to 3 years. Hopefully, with a vaccine that could get developed quickly, we might be able to blunt some of those waves or even end the pandemic sooner. But of course, we hadn't ever been faced with a vaccine developed with that kind of speed. So we had these scenarios that played out where people predicted even just a few months into the pandemic that we would have this hammer and the dance kind of approach where we would have to have tough restrictions put in place, get things under control a bit more, things would lighten, and then as restrictions were lifted, you would start to then see a resurgence of cases again, and you'd again have to do some restrictions. So this was all predicted very early on in the pandemic, and of course, this is how it played out globally. I think another learning from the background is just that inequities in who was being infected, who experienced complications, the deaths that we saw. Again, much of that was predicted, that we would see these kinds of disparities in infection rates and complications in different subgroups, as well as potentially unintended consequences of our response itself. The restrictions that were needed played out differentially in different populations. But of course, we had to act swiftly to prevent the health system being overwhelmed, and so that took precedence. But then mitigating measures came into play, where understanding what some of these unintended consequences would be, governments at various levels tried to put in place certain types of programs and policies that were aimed at mitigating those unintended consequences, and at the same time easing the negative impacts to the economy as well. So we saw things like income support programs for both businesses and workers that were affected by closures as one example, as well as targeted funding for areas like mental health and enhancements to long-term care, etc. We'll go through those in a little more detail a little bit later on. I guess also last thing in the background is that very early on there was unprecedented focus on vaccine development, production, and deployment. And this was building upon work from previous SARS outbreak from the early 2000s and other vaccine work on other coronaviruses that had been going on. So there was a foundation to build upon, certainly, but novel technology such as mRNA vaccines and building on other promising vaccine development platforms allowed many companies to start building potential vaccines quite quickly. But early on, it became very obvious that while we had some great primary research going on in Canada, we didn't have access to some of the equipment, supplies, and production facilities to do domestic production. And that would hamper our ability to get our hands on vaccine perhaps as quickly as some other places. At the same time, we had a lot of COVID fatigue setting in as we had wave after wave come on, both fatigue in the real sense from workers that were affected by COVID patients, but also fatigue in terms of the response. And we saw what many have called an infodemic of misinformation then starting up fairly early on, actually, and then going through waves as well. But this has had the unfortunate impact of delaying our ability to get herd immunity. This has been coupled, of course, with emergence of various variants of concern, which have been more transmissible and have added to this context and this anxiety. So ongoing debates, the stage we're at right now, on the need for ongoing mitigation measures and whether we should have requirements for vaccination as the next phase of response before we can actually get to what people are calling living with COVID. Because as you know, this isn't going away anytime soon. We are going to have SARS-CoV-2 with us eventually as an endemic virus. Hopefully it'll change into a less serious form over time, but we could also have variants that are more serious in at least the short term. So before we get to living with COVID, we need to start dealing with the variants that we have right now. And that's what we'll be talking about in the next few slides. So again, just as a brief introduction here, just looking at some of these unprecedented speed and comprehensiveness of some of the initial interventions that we saw with COVID. And who would have thought just a few years ago that we would be in a situation where global travel and commerce was shut down to the extent it was within just a number of weeks. Travel restrictions being put in place, border closures with our neighbors to the south, businesses shut down and businesses adapting to curbside pickup and people getting used to wearing masks and physical distancing very, very quickly from nothing to these kinds of full lockdowns within the space of a couple of months. And where have we been at? Well, this is the most recent data pulled from just before the conference here. You can very clearly see in Canada the first wave that came in the spring, a little bit of a bump up in the summer as some people, some certain provinces released some restrictions with some targeted outbreaks that happened. But then the true second wave hitting last fall with a bit of a reduction happening as immunization programs just started rolling out toward the end of December, early January. But then the third wave happening as we hit into March, and variants of concern circulating and starting to take over from the original COVID. And then again, rapid reduction now as more of the population was immunized, and we hit to summer again with more outdoor activities happening. But then vaccine programs stalling mid-summer with the emergence or overtaking, I guess, of Delta as the variant of concern, more transmissible, and starting to see this fourth wave primarily in the unvaccinated population taking off here as we hit into late summer and start into the fall. Similarly, our peaks you can see in hospitalized patients, patients in ICU, and those requiring ventilation. Again, just the curve follows the same pattern. It's just delayed slightly by a week or two, and of course decreasing in its amplitude because of fixed percentages of people in different groups who get seriously enough ill that require hospitalization, ICU, or ventilation, and of course deaths following a similar pattern, again with a bit lower trajectory. So this is not news to you, but just from the epidemiology. Interesting to see that already even we're starting to see an uptick in hospitalized patients and ICU patients, just barely delayed by a few weeks from this fourth wave starting in Canada. But the change now is happening with the distribution of these cases according to vaccination status. So this is what I was talking about, a pandemic now primarily in the unvaccinated population. Interestingly, the numbers are a bit different than the percentage. People are getting confused about this, but we still have relatively high numbers of people who are coming down with COVID in the fully vaccinated or partially vaccinated. But because the majority of the population is fully vaccinated or partially, even a small percentage of people that have these breakthrough infections still leads to a fairly large number. But you can see that most of the cases are certainly in that unvaccinated population, as well as hospitalizations and deaths. Some differences starting to come out now around deaths and hospitalization rates upticking a bit in the fully immunized, particularly in older populations or more vulnerable populations who may have been immunized earlier, and a question as to whether that's due to waning immunity over time or perhaps less effectiveness in that subpopulation from the beginning. Again, underscoring the fact that we need to have everyone immunized in order to really get this under control and continue to protect our most vulnerable. So, as I said, these initial responses, the complete stoppage of international travel for a while, and then certainly a massive reduction from there on. Variation in terms of the extent to which places had lockdowns, whether full or partial, and that varied over time as well. Work from home becoming a big thing, but only for some, of course. There's many of us who can't work from home, including those of us who work in clinical medicine, who have to take care of our patients in the hospital, for example. Others, like myself, working in public health, most of the work could be done from home. But also we had a lot of other workers that were deemed essential who worked in very public front-facing positions, often at minimum wage, that didn't have the ability to work from home. We had school closures in many places, followed by a change or adaptation to the way school was delivered to try and make it safer and allow children still to be in school. Social or physical distancing, as it was called, and of course hand hygiene and use of personal protective equipment, including masking. But I think very quickly what we've learned is that the response to COVID is a continuum, and you've probably all seen now this Swiss cheese model that people have, showing that any protection that we have has holes in it, and the idea is to layer these responses to minimize the chance of being exposed to COVID. So we have many personal responsibilities and many that are shared responsibilities, and if you can layer these protections more together, it's more effective in stopping this pandemic. And you'll notice vaccines at the very tail end of this continuum, first of all, because it takes time to develop that vaccine, but also no vaccine is perfect, as you know, and immunity can wane over time. So we need to have these layered protections in place to get a handle on the pandemic. So let's switch now and talk about the indirect impacts of our response. We know that these responses were necessary. From a public health perspective, we knew they would be effective. We learned, as we learned more about this virus, about the increasing role of airborne spread versus what we've had for many other respiratory infections, where droplets were the main issue, and therefore a good balance between personal hygiene and physical distancing was enough. Here we knew that masking was going to be needed and improved ventilation. But as we're getting used to this response, the initial response had to be very blunt and frustrating, in the sense that we seem to be relying on infection prevention and control measures from a century ago in order to handle this new virus. So we had examples of just the need to shut down so many programs and services, leading to delayed acquisition of health services and appointments, diagnoses delayed, treatments were delayed. Many preventive services had to be completely canceled in the community, many supports that people needed, especially the vulnerable. And of course, many missed appointments, even for those that were adapted. People who were afraid to go out in public or especially into healthcare facilities where the COVID patients were, meant that many were missing appointments. And of course, isolation. As this dragged on, the negative effects of just being cut off from others as social beings led to poor mental health. Those with underlying mental health problems often saw those exacerbated, so increased stress and anxiety. As people were crowded together, if they were in unstable situations, the threat of family violence was more acute. And of course, all of the community supports and services that were needed were closed for a while and then drastically reduced or adapted to the extent they could be. So a lot of prediction at that point about worsening medical conditions, things like increased alcohol consumption, substance abuse, and the opioid crisis. All of those things were predicted to get worse, and most of them did come to pass. And then, of course, the economic losses and the business closures, of course, that we've seen. So in order to prevent the unnecessary deaths and our drain on healthcare resources, there were also negative impacts on the other side, of which I've just listed a few. But of course, we've also had indirect positive responses. I've got a picture there up in the upper right-hand corner of air quality improvements in northern Italy after their initial lockdown in the early phases of the pandemic, and tracking their improvements in air quality in multiple cities across the world over that course of that initial lockdown. Of course, that reduced air pollution was very much short-term, but it did show the impact of a lot of the travel that we have on air quality. Virtual medicine, things that technology had been there, a lot of people asking for this and looking for ways to try to implement when it's forced upon you. Quick development happened, and many of us got used to virtual appointments with patients, as well as virtual appointments for meetings, and Zoom and other platforms used for that kind of video conferencing. Everyone certainly has become much more adept at using, and it's shown what's possible and also what the limitations are of that kind of meeting. We've seen a lot of business innovation, so businesses pivoting where they could for increased service like curbside pickup or online ordering, including local stores doing online ordering and delivery. A lot of move from the public to try to support those local businesses as well. And of course, adaptations to domestic supply. Some businesses pivoting to use their manufacturing capacity to provide the types of supply that we needed to respond to the pandemic. More time with family as well. Some people have said you should list that in the positive and the negative. There's been a lot of stress as well with school closures and people having to stay home until test results could be delivered. Blurring of the space between the home space and the workspace, but there has been more time spent together as family as well. People pivoting where they spent their dollars, and if they weren't spending it on travel and had extra time on their hand, we saw odd things all of a sudden come to the fore with home renovations, for example, making it virtually impossible to find somebody to do that kind of work or to find supplies. And of course, also positive impacts like government supports and services, where there was rapid deployment of various economic incentives like the CERB for those that had lost work, and just showing that it was possible for government to respond quickly to give income supports for those who were in need was an interesting positive example for us to think about in terms of whether government can pivot to things like a basic annual income into the future. So equity considerations. I mentioned that there was early on a prediction that both COVID and our COVID response could impact subpopulations inequitably. So we knew that there were pre-existing inequities in our society and the social determinants of health, and that this could lead to increased impacts of COVID. And in fact, that's what we did find with various types of disenfranchised populations, or those that were put at extra risk just because of the nature of both the disease and our response. So subpopulations, such as racialized populations, those in lower socioeconomic status, as an example, those with pre-existing conditions or either medical or from a social perspective. And what we saw in many studies done, both in Canada and abroad, is that this resulted in both increased case rates, hospitalizations, and deaths in these subpopulations due to COVID. And also it has now in the last few months also been shown to reduce vaccine uptake, just in the way that the initial mass vaccine programs were administered, making it more difficult for certain groups to get access, but also underlying distrust in subpopulations because of, again, pre-existing inequities in the way the system has treated people in the past. But also our COVID response has had increased negative impacts on the vulnerable. So the very fact that we needed to reduce certain programs and services that resulted in more congregation of people while we couldn't get personal protective equipment to the workers, loss of income for those who were out of a job, increased stress and anxiety, in some cases just inability to follow the public health measures because of pre-existing living conditions, overcrowding, or the need to go to what was deemed an essential workplace, the need to take public transit to get there. And as I said, underlying distrust of government or authorities based on how people have been experiencing services in the past. All of those things led to more exposure, and if exposed, worse outcomes, often in subpopulations. So it's been explained by researchers in this field that COVID both shone a spotlight on pre-existing inequities and served to amplify their impacts as well. This is just an example of a framework that was put together by our Chief Public Health Officer of Canada in late 2020, looking at how both the disease and the public health measures themselves interfaced with these structural determinants of health and intermediate determinants to produce differential health and well-being outcomes. And of course, key factors at play there being underlying stigma and discrimination and social cohesion or connectedness issues. Again, not unforeseen, certainly. So what have we learned from this? Well, I think we've certainly looked at our need for surge capacity, certainly in my field in public health, since well before this, even with the first SARS crisis that we had back in the early 2000s. It was recognized that when a big public health issue came, we were operating so close to the margin that there was not surge capacity to deal with extra contact tracing and vaccine delivery and testing and all the things that we need to do to contain a large pandemic. But the same was true in the healthcare system, that we're running at full capacity most of the time, or so close to that margin that any surge in capacity puts us into crisis mode. So we have to learn from that in terms of creating enough surge capacity and leaving some reserve, especially when we can model and predict out into the future where these surges are going to occur. And issues like cross-training of staff and other factors related to human resources that we'll talk about in a few minutes could be some things that we can look for into the future. We got caught without a domestic supply for certain key personal protective equipment supplies, certain drugs, and of course, as I mentioned already, vaccine development and production. Certainly we learned that the hard way. We've relearned, I suppose, the value of epidemiology and modeling for planning so that we can have time to prepare in most cases, unless the issue, of course, starts with you locally. The effectiveness of basic infection control measures, masks, distancing, ventilation, hand hygiene, as I say, these things that we've known about for over 100 years, but they become our bedrock for controlling something that is this new and should be retained as an ongoing best practice even as the pandemic passes. Health system transition timing challenges, not something we could do about here, but in Saskatchewan we just happened to be mid-transition or early on in our health system transition to the new single health authority, and that meant 10,000 policies that had to be harmonized, including a pandemic plan. Our emergency response structure and how does that function in a single health authority compared to what had been in place with multiple authorities, or even our move to health networks and how public health is integrated into those. All of that was mid-transition and of course just made it more challenging to get up and running with a pandemic response. Thankfully, we weren't at the leading edge of that and had some time to learn, but as we now come out of 3 waves of this and start trying to look at how to change the system and continue on with our transition plans, what have we learned from the pandemic that allows us to perhaps tweak some of those plans to make sure the system is best tuned to manage these types of public health issues? Of course, the importance of an infrastructure for infection control. We had many recommendations across the country after the last SARS crisis for improving or enhancing our infection control infrastructure, including the need for various types of screening areas and positive pressure rooms and infection control practitioners, etc. Ongoing training and preparedness like fit testing for masks, even things like the role of mandatory immunization. We knew about all of this, and it certainly hit home during the pandemic about the need to embed this into our culture. We've certainly seen that investments are needed in our long-term care areas across the country. We've seen from many previous outbreaks, even as early as I started in my career in the mid-90s, outbreaks of antibiotic-resistant organisms in hospitals and long-term care. It was already talked about way back then about the need for investments in better infection control, less patient movement between rooms, less stacking of people one upon the other, better infection control, etc., better working conditions, payment of staff, etc., in our long-term care, but also then things like mandatory immunization for those working with our most vulnerable. These have all been things we've talked about for many years, and again, we've had to relearn that lesson during the pandemic. Also, the need for enhancements to our mental health system, very much underscored during this pandemic. And of course, our public health system. We've had many examples over the years where we have a public health crisis and there's short-term injection of supports. And then as the crisis fades from memory, cuts happening again without the understanding that a sustained investment in that type of prevention capacity is needed to avert more of those crises into the future. Just of note, I've got a reference here. There are multiple reports underway at the national level right now, already starting to deconstruct what went well, what didn't, and how to strengthen the public health system in Canada specifically. The importance of mandatory immunization of healthcare workers. We have lots of examples of mandatory immunization for other types of diseases if you want to work in the healthcare system. COVID has again brought home the need for that to be considered for some of these other respiratory conditions as well. Data linkage. We've had a problem in Canada in not being able to access all of the data that we need to actually manage this pandemic or to compare work across jurisdictions for both planning and research, both in public health and to some extent linkage with public health data and the healthcare system data. We need more investment in a population health approach overall in the health system as well as the public health system. So that continuum of care, of prevention, health promotion, health protection, and surveillance that makes up the bedrock of public health, but then aspects of that need to be applied in the rest of the system as well. We've learned the lesson of needing to clarify the role of the public health leaders and have them placed appropriately within an org structure and with the autonomy to give public recommendations. There's been a lot of centralization of control of the message, leading to more nationalism and politicization of the pandemic. And this unfortunately has led to a polarization of response and attitudes in the public, and to some extent eroding public trust in science, both among the public and in politicians. I think I've heard a number of people working in the healthcare system say, I guess we're not heroes anymore. There was a time in the initial wave, in the initial response, where there was a lot of outpouring of thanks for the health system. But as pandemic fatigue has set in, more and more negative reaction to speaking the truth and trying to speak science into policy. So I want to end off by rethinking or giving some reflection on how to rethink medicine in a post-pandemic world. I think we need to have a better balance in our quadruple aim from a quality perspective. So the perspective that we played in that, as we look at quality improvement from a healthy system, the health of the population, the health of our finances or the cost equation, and then our staffing and staff morale. All of those things need to be balanced. And what we find at times is there's more emphasis on the cost containment side and less on the balance of how you then achieve a healthy population, a healthy system, and a healthy staff in combination with trying to keep costs reasonable. And that imbalance has led to some perverse incentives and disinvestments in areas where I think we're paying the cost now. So I would certainly argue for a more balanced approach as costs go up or down, that we have to look at the whole continuum of that care and not disproportionately be cutting in one part of the system, which tends to usually be prevention, I would suggest. We need better cascading and synergistic public health system globally, nationally, provincially, and locally. We don't have a public health system per se in Canada. We have a collection of provincial public health systems without great integration in terms of our approach, as I said before, for data, but also just even in our policies and programs and ways to address that needs to certainly be fixed. I think we can rethink how we deliver public health and the governance of public health, and that's what many of these future public health reports that are going to be released this year are going to speak to, and we'll certainly be trying to look at those recommendations here in Saskatchewan as well. We need better linked health data, and there's a pan-Canadian health data strategy that's being released as a result of some of the challenges we've seen during the pandemic that you can look for in December that will help us rethink our health data strategy, both for delivering care with that data and analyzing and doing better planning, but also for the health research that's going to be needed to help us build back stronger. I think we need to look at mandatory immunization much more seriously. If you're going to work in healthcare, and especially with our most vulnerable populations, there are certain things that we just have to do. It's less about individual rights and more about a balance of rights and responsibilities, and what does the work require? And I think we have other ongoing measures as well that we may want to think about. Who could believe that wearing masks, staying home when you were sick, and having more physical distancing actually made the influenza season virtually disappear this last year? So many people saying they can't remember the time when they've had so few colds even. So we know the effectiveness of these measures. So to what extent can we make this more a policy about staying home when we're sick, wearing masks when we're not feeling ill, and trying to maintain that distancing, hand hygiene, etc. Virtual care. I think we need to rethink that as well. Certainly, we don't have to have all virtual care. We know it's here to stay, but in what circumstances is it actually going to be an enhancement and ongoing? Where does it best apply, and where do we reach that balance of virtual care versus the in-person care? A lot of rethinking needs to be done in that area as we come out of this pandemic. Less conference and physical meeting travel, essentially, both from a Healthy Planet perspective, but also we've just shown that a lot of the benefits can actually be achieved with virtual meetings. I'm certainly of the opinion I understand the value of in-person meeting and certain types of physical conferences as well, but there's an opportunity to have more options around virtual meeting participation along with physical for both conferences and meetings, decreasing the number of people that need to travel as well. So I think there's a lot more discussion and rethinking about how to best adapt this virtual technology for both our care and our meeting time, and recognizing that in-person still has its place, but rethinking when and where. I think the work-life balance issue, we haven't had a lot of work-life balance for the last 18 months in healthcare. It has led to a lot of people rethinking their priorities, and we also had to rely on a lot of emergency measures to get cross-jurisdiction coverage and support to have staff flow to help out parts of the system that were being overwhelmed. How do we build back in a way that allows for that to happen more organically and for the system to flex and help each other out and allow us all to then have better work-life balance over time and respond to these crises more effectively? I would also say that we need to rethink our actions on social determinants of health. Certainly, Saskatchewan has been a leader at trying to incorporate some of these concepts of health equity and acting on social determinants as part of our quality improvement in the health system. I think we still have a long way to go, though, and others are catching up. We should be more routinely collecting information about those factors that have such a huge impact on the health of our patients, but also on their ability to follow our advice or care plan and discharge planning. It's no wonder we have differential outcomes and differential quality when people are starting from such different points and have different types of supports available to them. So how do we make that more routine, to be incorporating our learnings on the impact of social determinants on the health of our patients wherever they present in the system, and adapt our care plans and discharge plans according to that need, so we don't have this ongoing revolving door of individuals who get stabilized within the health system and then discharged into the same conditions that made them sick in the first place. Also, health needs to collaborate with other sectors for this work, and more collaborative work on a health in all policies approach, where we see that sometimes policies passed by other parts of our government or other parts of the system have negative impacts on health, and we need to work more collaboratively to seeing healthy public policy. I've mentioned already the investments needed in long-term care, mental health, public health, and in our social safety net as well, though health can't be eating everybody else's lunch. We need to have a basic understanding of both the public and politicians that austerity kills. We need to have a baseline investment in things that make the citizenry healthy and have better well-being. That might mean health advocating for things like basic income guarantees, a living wage, paid sick leave so people can in fact stay home when they're sick, more funding for the education system and not cuts to education because health has a large budget ask, as an example. We need to approach this collectively, seeing that investing in these types of supports and services is just as much an investment as health as investing in the healthcare system, or perhaps even more. There's a certain amount of large issues globally that I think we've seen through the pandemic amplified, as I said, that we need to start thinking more globally, thinking larger as medicine. Health in all policies can be applied, as I said, at local, provincial, national, and international levels. But if we look around, we've had global work going on sustainable development goals now for many years. And how does health factor into that? The North-South economic inequality issues. We've certainly seen that amplified in how COVID has played out in different countries with different types of supports, healthcare systems, or needs, but also on vaccine supply and acquisition and delivery. So we need to reinstill more a sense of community and balance between people's rights and responsibilities. There's been an abundance of people discussing rights being taken away without an understanding that with rights come a lot of responsibilities. We seem to have lost that perspective of our sense of community and our need to respond to things collectively for the common good. I think the last thing I would just point to is the interconnectedness that this pandemic has shown us, because we've seen amplification of the consequences of the pandemic in various subpopulations, as I said, but at the same time we've had stark examples of climate change hitting us in these past 2 years, or coincident with the pandemic. We've seen huge issues around racial tensions, issues like Black Lives Matter and the residential school unmarked grave sites. But we've also seen some of the most vulnerable in society, those issues getting worse, like our opioid crisis, or huge escalation in syphilis outbreaks, as an example. So we've just seen how much society is interconnected, and the pandemic has exposed some of those vulnerabilities and amplified them, and has caused a lot of people to think more about what's our role in the larger community context, helping to make the conditions where people can live healthier. And it's not just about our role as healthcare practitioners patching people up and sending them back into those conditions. How do we change our medicine, the way we deliver care, in the context of being aware of and responding to these larger issues like climate change? How do we change the way we're interfacing with our patients so that we're understanding the trauma people have been under, the ongoing trauma people are experiencing, and particularly those most vulnerable. so that our system, our health system, isn't contributing to those traumas, but actually having a more trauma-informed care and therapy perspective. And of course, prioritizing the types of services that are going to both respond to the immediate crises that people that are marginalized are experiencing, but also in terms of the supports and services that are needed to respond most both now and to change the proportion of people experiencing those into the future by better balancing where our program and service dollars go. So I'll just close with this other graphic that was also in this report from Risk to Resilience from our Chief Public Health Officer of Canada, showing that the pandemic has, we had this initial crisis response, both with new actions and rapid innovations that had to get developed in policies and programs. But it's resulted also in shifts in values and attitudes, people rethinking what's important. And what we need to do now is develop new ways of living and working in response to that so that we can build back stronger by reducing stigma and discrimination, looking at those improvements that we need in our infrastructure, like our governance models, our data systems, our communication, and focusing more on really high impact areas of action, things like environmental sustainability, things like the interconnectedness of our health, social service, and education systems, the underlying conditions that actually make it possible to follow the health advice they're being given, like stable housing and a healthy built environment. And of course, the bedrock of economic security and employment conditions of our society. We've certainly seen that the inequities in many of these areas has actually had huge impacts on our pandemic response in Canada and who's impacted by it. So how do we build back stronger, both as a society, as individuals, and as a medical profession and a healthcare system? So just in final thoughts, we need to learn from the crisis that we've experienced and our responses to it, build back stronger, particularly with our public health system and our primary healthcare capacity. We need a stronger population health approach in all of healthcare. We need to strengthen our health data strategies and data collection, data linkage, data sharing, so that we're better able to respond more quickly. We need to redevelop our domestic vaccine and medical supply chain for personal protective equipment and drugs. We need to certainly fix holes in our social safety nets to improve population health and deal with any unintended consequences for future crises. Personally, I know that our public health systems and services research is woefully inadequate in this country, and it's needed to point out the areas of largest concern in our part of the healthcare system and evaluate those changes over time so that we're better prepared into the future. And I'm sure each of you in your areas of medicine can also think of where the holes in the research are that we need to start working on immediately as we emerge from this pandemic as well. So I just want to thank you for allowing me this time to share with you and do a little bit of reflection. We're certainly not out of this pandemic yet. As I'm speaking to you, the fourth wave is just really begun and remains to be seen where we're going to go. But it's never too early to start thinking about the changes needed to respond into the future. So thank you again, and I hope you enjoy the rest of the conference.